So we're gonna just look at, just go over the basic echo. So again, when you start with your parasternal long axis, and if you remember how you get your parasternal long axis, the transducer, the probe is in the left uh, third or fourth intercostal space, and the mark is towards the patient right shoulder. And you're going to get something looking like this. The chest wall is right here. Of course, you have your transducer right up here. So the transducer is located right here. The chest wall is right there. Below the chest wall, of course, you have the pericardium, then the RV wall. This is the RV cavity right here. This is your septum, ventricular septum. This is the left ventricle. The mitral valve is right here. This is the anterior mitral leaflet, posterior mitral leaflet, and this is the posterior wall. Okay, the left atrium is right there. The aortic valve is closed, and this is the aortic root and the ascending aorta. So let's put it in play. So in systole, you can see that the septum moves towards the posterior wall, or the posterior wall moves towards the septum, and not only that, but the muscle thickens. So when it contracts, the muscle thickens. In systole, the aortic valve opens, in diastole closes, and then in systole, the mitral valve closes and it's open in diastole. So that's what we've been saying. Okay. All right. So we have not done M mode, so we're not gonna we're not gonna mention that. We're not gonna do M mode at all. Okay, we have not done color, so we're not gonna do that. All right, so again, the measurements. So you measure your septum. Measurement should be done at the tip of the mitral leaflet, but again, you're going to measure perpendicular to the LV axis, and it's very important. So even though we say it, people are not doing it. So the LV axis is going to be like this. The LV axis is going to come like that. So your measurement should be like this. It should be perpendicular. So the tip of the mitral leaflet, so it should be like that. Okay. So so you have to have proper orientation, and then you measure your septum and your posterior wall. Okay, so again, in systole, your aortic valve opens. In diastole, the mitral valve opens. When the heart contracts, the muscle thickens. So this is your right ventricular inflow view. Okay, so of course your right ventricle is on top, the right atrium is below. This is the tricuspid valve, the posterior leaflet, and the anterior leaflet. So short axis at the level of the aorta, you can see there are three leaflets. So to get your short axis, you start at the parasternal long axis, That is the third or fourth left intercostal space, the marker pointing towards the right shoulder, and you're going to rotate clockwise to about the 1 o'clock position. The angle of the transducer should be downwards, and you're looking at the aorta. Okay, so some important landmark. This is your atrial septum is right there. The right atrium is right there. Left atrium. Remember, your atrial septum is adjacent to the non-coronary cusp. This will be the right, and this will be the left. Okay. In most exams, they want you to name the cusp. Of course, your tricuspid valve is over here. The pulmonary valve is right over there. Okay, so you will find that the exam just basically testing basic knowledge, things that you should know. So if you just know the basics, you're ensured to pass the exam. But you have to know the basics very well. Okay, we're not doing color. So remember now, so to get the short axis at the level of the aorta, the angle of the transducer is downwards. And then you're going to move to the base. To get to the base, then you have to move the angle of the transducer upwards. When we say the base of the heart, we're talking about where the mitral valve is located. All right, so we're still looking at the aortic valve. Okay, so and you can zoom it, because especially in young individuals, you want to identify your three cusps. So if you're not seeing it clearly, you have to zoom it. The tricuspid valve is over here, pulmonary valve is right there. The septal leaflet is here and the anterior leaflet. So remember, okay, septal leaflet of the tricuspid valve is right there, and the anterior leaflet is over there. So, you need to know how to name the different structures because, the exam is filled with that. So again, so you're going to move the handle of the transducer upwards, and then this is the base. Okay, so at the base you have the mitral valve, of course, and remember what we said, this is the anterior wall up top, this is the inferior wall below. Okay, the lateral wall is over here, and the septum is right here. Okay, septum, and this is the lateral wall. But we divide the lateral wall into an anterior lateral and an inferior lateral. And we divide the septum into an anterior septum over here and inferior septum. Okay, so when we look at the short axis at the base, we have 6 segments. Okay, remember you have to know your segments. So we have 6 segments. So the base where you have the mitral valve. So if you lift the angle of the transducer further upward, then you'll get to the mid cavity level where you have your papillary muscles. Okay, so we're still at the base with the mitral valve. The anterior leaflet is on top and the posterior leaflet is below. So we're raising the angle of the transducer upwards. So we're going to get at the mid cavity level. And at the mid cavity, we have the papillary muscles. Okay. So this is your anterior lateral papillary muscle and your posterior medial papillary muscles. Anterior lateral, posterior medial. And then you have 6 segments again. This is the anterior wall up top. This is the inferior wall below. The lateral wall is over here and the septum is right there. But the lateral wall, we divide it into an anterior lateral wall up top and the inferior lateral wall below. The septum, we have an inferior septum right here, and we have an anterior septum. Okay, Again, when the heart contracts, it comes in. So if you have a little point right there, you can see that when the heart contracts, everything moves towards the point. Okay, so if you have a point right there, you can see it move towards. Okay, the muscle thickens during systole. Now to get to the apex, you just move the angle of the transducer further upwards, and you get to the apex. Okay, so you just move the angle of the transducer further upwards, and the apex of the heart. We only describe 4 segments. You have an anterior up top, inferior below. This is the lateral segment, and this is your septal. Okay, so this is at the level of the apex. So again, remember, it's practice, practice, practice. Okay, so the 4-chamber view. So you're gonna locate the apex of the heart, or the mid-clavicular line, and the 5th intercostal space, and your marker is point towards the 4 or 5 o'clock position, and you get your 4-chamber view. So you need to have an idea what your 4-chamber view looks like, because if you don't know what it looks like, you're not get it. So you need to have a clear picture. So this is actually a 5-chamber view, but you know, to get the 5-chamber view, you from the 4-chamber view, you're gonna pull the angle of the transducer downwards a little bit, and then you open the aortic valve, and you can see the aortic root right there. So again, so if we're gonna do the ejection fraction, as we mentioned before, you're gonna trace the endocardial border in diastole. So in diastole or end diastole, you trace, okay, you trace the endocardial border. Okay. So trace it, and the computer will give you a volume, and then in systole, you do the same thing. You trace the endocardial border in systole. So diastole is when, you do it in end diastole when it's fully uh, dilated and filled with blood. Okay, and then in systole, you do the same thing. So remember, systole is, you can say the peak of the T wave. Okay, and then so if you do it in diastole, you're going to do the same thing in systole. You trace the endocardial border. Okay, and then so your ejection fraction is, so your ejection fraction that's equal to your end diastolic volume. This thing doesn't wanna. So it's equal to your end diastolic volume. Yeah, my pen doesn't want to write, so just bear with me a little bit. So your end diastolic volume says E. It doesn't even want, yeah, okay. So this is actually a D. So it's the end diastolic volume. You're gonna minus your end systolic volume. And you're gonna divide by your end diastolic volume. So that's what the computer does. But if you know the values, you can do it yourself. Okay. And so it's about 55 over end diastolic volume, about 55 to 70. Okay. But the values differ somewhat for males and females. So the updated uh, the updated information gives you the ejection fraction for male and the ejection fraction for females. So this is your ejection fraction. But you can just, you can look at it and get a good idea. If you look at this, you can see it. So you need to have a good impression of what a normal ejection fraction looks like. So this is fairly normal. You can see it comes in, it thickens with contraction. Okay, so this ejection fraction is probably about 55–60% thereabout. Okay, so you need to look at a lot of normals so that when you see an abnormal study, you know exactly that's an abnormal study. So let's look at an abnormal study now. So you can let's look at an abnormal study. Let's and this might take you a little time to get, but once you get it, I think you'll be okay. All right. So again, when you do any study, you always start with the parasternal lung and you work your way through the study. You know, you have to do your measurements. So you do your parasternal lung and you do your measurements and stuff like that. You look at the wall, but you're gonna form an impression. You know, you're gonna form an impression, and you're gonna do your measurement to see if the wall, the septum and the posterior wall is thickened. You want to see if the cavity size is dilated. Okay. So you're gonna go through your normal stuff. So I advise you guys to look at a lot of normal studies. Okay, so you have to, once you know when something is normal, if it's abnormal, you might not be able to pinpoint the exact abnormality, but you can say this is abnormal. So if you don't know what's normal, you won't be, you won't be able to say that. So we are now short axis. I want to go to the parasternal, sorry, the apical four chamber view. So we're still on the parasternal. Okay. All right. Short axis. Okay. And by now you guys should be developing your protocol, or what format you're gonna adopt in doing your study. So you should be working on that now. Okay. I mean, you can add on to it as you learn more stuff, but you should have a basic protocol, and then as you learn more stuff, you can get a more robust protocol. All right, so all right, let's move on to taking a long time. Let's see. Wow, still on the parasternal. All right, so this is your apical four chamber view. So just looking at it, and you can see it's not contracting as vigorous as the one we saw before. So if we were to get the ejection fraction, we trace the endocardial border in diastole, and then in systole we do the same thing. The ejection fraction is going to be reduced. Okay, let's look at it. So if you've been looking at a lot of normal studies, you can right away recognize that this ejection fraction is reduced. It's not normal. And then once you once you have a lot of studies under your belt, then you can I mean, you should always do your ejection fraction, but sometimes you can eyeball it and you know give a fairly accurate ejection fraction. Okay, so all right, so look at it, you can see this is not as robust as it's not contracting as well as the one you saw before. Okay, let's look at it. Okay, so to get the ejection fraction, you plane the planimetry endocardial border and diastole, and you do the same thing in end systole. Then you subtract from the end diastolic volume the end systolic volume, and you divide by the end diastolic volume, and you get the ejection fraction. Okay, we look at other methods of getting looking at the systolic function, we talk about the stroke volume, and the stroke volume is the volume of blood that's pumped out of the heart per beat, and the stroke volume is the end diastolic volume minus the end systolic volume. That's the stroke volume. We talk about the cardiac output, which is the stroke volume times the heart rate. So that's the volume of blood that's pumped out from the heart per minute. We also talk about the shortening fraction, fractional shortening, okay, which is a linear measurement. We look at the LV cavity size in diastole, and we subtract from that the LV cavity size in systole, and we divide that by the LV cavity size in diastole. It's a linear measurement. So those are the methods that we use for LV systolic function. And we also talk about the segments, the different segments, and the blood supply to the different segments. So the exam is gonna be, let's see, the exam is gonna be I think the 18th of May. The exam is going to be the 18th of May, so you have a little over 2 weeks to prepare for it. Okay. All right. So just want to go over this so that you have an idea of what a reduced ejection fraction looks like.